So I'm an IVF clinician. I work in Shaarei Tzedek Medical Center, which is located in the center of Jerusalem. I will present today our internet-based system for transferring medical orders in IVF unit. We presented the preliminary experience in the ASRM meeting in 2009, and I will show our experience, gain, and some thoughts as a result of our experience in 3 years of implementing the system. So why do we need a computerized system to communicate with our patients at all? And the reason is to try to improve care of our patients. Infertility for itself is associated with negative emotions and high levels of stress and depression. Now, treatments, especially IVF, specifically add further to this emotional stress. Stress may even perhaps negatively affect treatment outcome. Now, the treatment is intense and demanding. It means many times that somebody else controls your schedule, affecting your work and your personal life, other activities. Sometimes you're even told when to have and when not to have sex. So some women sense unconfidence, loss of control, and frustration through the entire process. We can see this in this demonstration. Why do people drop out of IVF? Dropout rates are pretty high. And it means it was found in several studies in different countries, different societies, that the most frequent cited reason for dropout is not poor prognosis for success. It's not medical difficulties. It's not physical difficulties. It's even not cost. It's physical burden. It's emotional difficulty. So what can we do about this? This is a recent study by Dept from the Jan Kremers group in the Netherlands. Is doing an excellent, very thorough job about this. And what they did is they interviewed patients from different countries in Europe about an attempt to define actually what does patient-centered care in infertility, what does it actually mean? So one thing important for patients is accessibility. Now, can we provide it? For example, taking medical orders on the phone usually takes a lot of time. Since personnel are few, and patients are always many, the result is an administrative bottleneck, busy phone lines, and inaccessible nurses, leading again to anger, to frustration. This is a patient satisfaction survey we conducted in our unit for internal users several years ago before implementing the computerized system. So you can see that our patients were pretty happy with their doctors, with the nurses, with the secretaries. They were very unsatisfied, very frustrated with the phone system because we were never available as they thought. The second reason we need in communication is for the team. Answering phones takes a lot of time. We've heard several times about emails, and I'm thinking to myself, answering emails is also very time-consuming. We still use fax sometimes. This is also time-consuming, so it's a serious origin of load of work on already busy teams. The third aspect is patient safety. We know it is well recognized that errors in medical treatment are common, major contributor to adverse outcomes. For example, I think that IVF is a single unique situation in medicine where non-chronic patients actually administer themselves, inject themselves medication daily, sometimes in very complex protocols and changing doses. So there's a huge potential for mistakes and errors here. We couldn't find any data accurately measuring the amount of such mistakes. We believe they are very common. Let's see, for example, one example. This is a report discussing a very mysterious biological phenomenon known as the empty follicle syndrome, in which mature follicles are aspirated, but there are no eggs inside. So this is very interesting. And when this group interviewed their patients following this unsuccessful procedure, they found that all 5 cases had problem with the final medication used to trigger ovulation, which is HCG. 2 of them took it 24 hours too late. 2 of them forgot it altogether, and 1 was given it by probably an unqualified nurse. So us doctors, we enjoy very much reporting other people's failures and complications, or good outcome has happened in this case after some error in the way. But I think this happens more common than reported. So our aim was therefore to improve patient care, convenience, and safety. Now, since computers are everywhere, both developed and developing societies, we try to develop an internet-based program that allows input of detailed instructions to the patients as to the medication and tests and schedule follow-ups. The software was designed by our own center's information technology department based on the IVF team's defined needs, with constant feedback still ongoing between the two teams throughout the entire process. So I'm not promoting sales of any commercial product right now, but a concept. I want to tell you also a little about the situation when we are acting, about our unit's activity, and especially the population. I think it's relevant in this context. So Israel total fertility rate here is the highest one, much above average of OECD countries. This is 2009 data. Now, this fits well with the insurance policy in our country. All citizens are entitled to coverage of IVF treatments up to 2 children or up to age 45 without an actual limitation on number of cycles possible. Now, many patients carry other insurance, complementary insurance, which provide coverage for the 3rd and 4th child. So having IVF for the 3rd and 4th and sometimes more children is an everyday thing in this country. So the final point is everybody who wants to do IVF and needs to do IVF can do IVF. Now, we're located in Jerusalem. Jerusalem has a population of about 1 million. It's mixed and very heterogeneous. Some are very educated people, but more than half are ultra-Orthodox. Orthodox Jews have a very specific lifestyle. About a third are Arabic-speaking Muslim community. So on average, the economic status is low compared with the rest of the country. Now, before developing the system, we conducted a survey and found that not all our patients master top technologies. Not everybody is well equipped as this individual here. This is just an example. I think they missed it yesterday about the talk about the top 10 technologies you need to master, so let's skip that one. So we found that about 70% of our patients has an easy access to the internet, at least on daytime. So this is an important figure. We are a university-affiliated public hospital. Last year, our activity included about 900 egg retrieval procedures. This includes about 100 PGD cycles, very complex treatment which attracts patients from all over the country, sometimes other countries, about 400 frozen embryo transfers, and various other ART procedures. We many times follow pregnancies at least to the end of the first trimester. So this is a lot of work compared with our staff. I will explain the regular framework. We take blood tests and ultrasound scans starting from 7 till about 10 a.m. Many patients do that in other facilities. They send the results throughout the day, usually by midday, let's say up to 2 p.m., mostly by fax. So as we have the results, medical orders are given starting from 11 to 2 p.m., sometimes later, and then nurses have to contact patients. So the load is about 100 phone calls on average per day. This is a lot of work. Now, this is a public practice, so we have a kind of a limited resource facility, although people are not paying, and recruiting more staff and more nurses is not that straightforward. So we are probably understaffed in office and nurse personnel for our needs. Now, this is why we have this administrative bottleneck, but it's not unique. You see such patients complaining about it from many countries. I will show you a little about the program itself. It may look strange to you because the interface is in Hebrew, which is written from right to left, so I'll try to translate what exactly is going on here. This is the main page, main screen the nurses see in every visit. Each line is a different patient. I erased them. And she marks a certain patient, and then she can choose any part of the treatment, for example, the stimulation phase or luteal phase, and so on. For convenience, for example, let's look at the stimulation phase. There are different protocols preset. For example, this is the microdose protocol. This is the long GnRH analog protocol. So you have it preset, and here what is written is exactly the name of the medication, the exact dose, times per day, the route of administration, and the date. Now we use antibiotics at this stage, so this is preset in the system. So it's pretty easy to use. This is a different example for a luteal phase. Now notice that the instructions are written in great detail. For example, when you have to take this vaginal suppository twice a day, patients are asked to lie down for 20 minutes after insertion. Now, what happens is that we notice that in oral communication, we try to speed up phone calls. You don't always get into these details, and there is confusion with patients, and then they feel they didn't get the right treatment. Now, again, the nurses can review the previous orders for this specific patient. Many of them have repeated cycles, so they can see what they got. They can copy it easily for ongoing orders. This is another example. This is, let's say, following, This is a protocol of choosing, let's say, following frozen embryo transfers. Automatically there is a text describing what has been done and how long you need to rest or whatever you want to write there, and when to return for a pregnancy test. So this goes pretty fast. Now, at the end of this stage, the nurse can review the entire list of medications written for a certain patient. In this case, for 2 days, and there's also a schedule for the next visit. Now, this is transferred automatically to the hospital appointment center. Now, what does the doctor do? The doctor needs to improve everything. So this takes time. He needs to sign it electronically. So the doctor gets this one page with all the orders of this specific day for all his patients listed one by one. For example, this patient here, she's pregnant, she gets a mazel tov message and has to continue these medications and return, let's say, in 3 days for another test. This patient here is not responding, so she's asked to stop medication and make an appointment. And this one has ongoing stimulation, and then the doctor, in a single step, signs it all. It's very easy, it takes just a minute. Otherwise, you wouldn't agree to do it. And it's sent to the website. Now, there are also a warning system. For example, here, the signature is missing. It won't be posted to the website, so you get a red alert. In this case, for example, double orders were given for the same day, so you get an alert box asking you if you want to cancel one of the orders for the same date. What happens with the patient? The patient gets a username and a personal code on the first visit. This is the hospital website, nothing fancy. She logs in. This is her personal page. Now, at each date, when she had orders, she can choose for the same date or for previous dates. So she can review what her orders were for before whenever she wants to. She gets to see a single page. This is the name of the unit. This is her name, personal name, and ID code. This is the date. She got orders here for 2 dates. It's only a single sheet. And again, there is a very precise description of what she needs to do, how she needs to do. The names appear both in English and in Hebrew. So there's really no place for confusion here. And the schedule for the next visit, she can print this easily because some of them go to other facilities to get their injections. So easily printable and very convenient for review. How do we know the patient actually got her orders? At a certain day, you have a list of patients who got orders on the computer on the same day. So this is a list of names right here. And if the patient is logged in and reviewed her orders, there's a check sign. So we know all these have reviewed their orders, and we know we should perhaps at the end of the day contact this patient because she didn't log in yet. So what were the results of all this project? I'll show it using an anonymous questionnaire for patients we conducted just recently. First, we've noticed that about 50% of our patients are using the system on a daily basis. Now, this was a little disappointing because we knew about 30% were not potential users, but we thought this would be more popular. Now, it took us some time to understand that we had at least one problem, and that is that because of our because some days are busier than others, sometimes orders are posted earlier, sometimes at 3 o'clock, patients kept logging in repeatedly, try to look when they have new orders. So again, you have the same bottleneck and the same frustration. So the solution we chose was pretty easy, and our developers implemented it in about 2 weeks. As soon as the doctors approve the medication, the patient gets an SMS alert through a cellular phone saying results are ready for you on the website. And this was the result of this step. This is the number of patients using the system we had since we began. It's pretty constant, and this is only the beginning of 2012, and for some reason the SMS was very popular and boosted up the use. We have some specific questions for those who use it. Now, about 80% of those eligible use the internet almost every time. And it's constantly growing, I think especially related to the smartphones being more popular, so people have easier access to the net. The phone service is still not good. People very unhappy with that, very unsatisfied. But we get the opposite picture with the internet service. Everybody's satisfied or very satisfied with that. We have some specific questions as well. Does it save time? For almost 90% of patients who use it, it saves time. Very satisfied about this. This was kind of a surprise. We asked them if to use it to recheck, to take another look at the orders. And this actually was the highest score. About 95% of patients need the opportunity or use it or appreciate it to take a look again at the orders. So there's something we need to know. I think we tend to sometimes overestimate our patients' needs and abilities, telling them what to do in a very short phone talk. Some of them perhaps need some time to look at it again. What about the SMS? About 75% found it useful and are happy with it. Now about the teams. Actually, we couldn't reduce much the number of phone calls. We'll try to discuss later on why. But the phone calls became very short. Very precise, very short, very effective. You just need to ask the patient if she understands, if she has any questions, she has their prescriptions, and that's it. So we think we saved about 50% of time of nurse workload dedicated to this mission. So let me summarize the advantages of the system. There's no need to wait for busy lines. It saves time, it's discreet, and it enables patients to review the orders again. Taken together, I think this care is improved, and we believe contributes to patient empowerment. It saves a lot of work for the personnel. And about safety, we know that we cannot change the human condition, but we can change the condition under which humans work. Obviously, documentation is a must now for medical legal purposes. We think there are possibly less mistakes. Now we're trying to run a study and actually measure it through detailed interviews, daily interviews with the patients, asking them simply exactly what they did. So we see if this is actually working, but in case there is a misunderstanding, there's no version gap anymore. And this happened to us before. And we know exactly where the error occurred. There are limitations. I think, first of all, you should know the population you're treating and their technological abilities and wishes. We found that our dedicated nurse did not feel confident for the system with a long time. Not technically, but I think they didn't feel confident with this kind of communication. Actually, this was the limiting step for spreading a wide use of this system, and perhaps this hesitation is a reflection of patient needs. So it's an emotional dimension for this. It's not a technical problem. The technique is easy. Some patients will always demand direct communication. They need to make sure they understand, they know what's going on, probably to feel confident. Also, it's not a technical problem, it's a personal thing. And last, and I think most important, we learned yesterday and today about so many sophisticated technologies and software. We should remember these are only technical aids for practicing medicine. They're not the core of practicing medicine. We never spread, for example, a negative pregnancy test on the net. This is done, of course, only in direct communication. There is no and should not be a technology that replaces compassionate, caring human interaction. I would like to thank all members of my team, especially Tzvia Maimoni, the chief nurse, which is the living spirit behind this project, and our dedicated programmers, Miriam Kluft and Maimo Dahan. Thank you for your attention.